Good evening, everyone. Welcome to Breast Cancer Symposium, Redefining Management for HR Positive Metastatic Breast Cancers, a virtual event brought to you by AstraZeneca Philippines in coordination with the Philippine Society of Medical Oncology. Please settle down, our event will start in a short while. Thank you. Please settle down, our event will start in a short while. Thank you. Let us pause for a while for a moment of prayer.
Father, praise you for
Let
this
us
event
pause for a while
and the
for a
purpose when we gather together. You always have a divine agenda. We love you for that, Father. But even we have done what you have asked, the results are so much greater than we ever could have imagined. Even in failed attempts, you blow us away with your faithfulness to provide what we need. Our prayer today is that your will be done in this event. Take what we have prepared and multiply our efforts as only you can. Steer our intentions to align with your righteous will. Remind us of your faithful Father. Any failed attempts, you blow us away with your faithful. Blanket us with your peace today, Father.
Good evening, everyone. Welcome to Breast Cancer Symposium, Redefining Management for HR Positive Metastatic Breast Cancers, a virtual event brought to you by AstraZeneca Philippines in coordination with the Philippine Society of Medical Oncology. To formally open tonight's webinar, may we call on Ms. Ana Mavel Rojas, Associate Brand Manager Oncology.
Evening, everyone. First of all, I would like to thank the Philippine Society of Medical Oncology for the opportunity to be of your partner in your continuing medical education, and we're looking forward for more continuous engagement as we have new and exciting launches in oncology that will definitely benefit our cancer patients. For tonight, I am excited to share with you the new approval in the indication of fulvestrant faslodex. Fulvestrant faslodex is now approved in the combination with CDK4/6 inhibitor for the treatment of HR positive, HER2 negative, locally advanced or metastatic breast cancer in postmenopausal women as initial endocrine based therapy or following disease progression on endocrine therapy. This will be further discussed by our speaker for tonight. Again, thank you to all our attendees for our virtual symposium for tonight. And I would like to welcome everyone to our Breast Cancer Symposium, Redefining Management for HR Positive Metastatic Breast Cancers. Again, good evening and thank you, everyone.
Thank you, Ma'am Mavel. We would like to remind everyone that this session is supported by AstraZeneca. The content is intended for healthcare professionals for medical education purposes only. Expert opinions of participating speakers are based on their experience to date. AstraZeneca does not engage in the promotion of unregistered products or unapproved indications. Please consult local prescribing information for registration and product license details. This time, let me call on our moderator for tonight, Dr. Kenneth Samala. He is a fellow of the Philippine of College of Physician, fellow of Philippine Society of Medical Oncology, and assistant training officer of the section of medical oncology, Jose Reyes Memorial Medical Center. He is also an active consultant at Manila Medical Center Manila and visiting consultant at Jose Reyes Memorial Medical Center, Our Lady of Lourdes Hospital and Manila Doctors Hospital, and clinical observership in thoracic oncology at Memorial Sloan Kettering Cancer Center, New York, USA. We shall now give the virtual floor to Dr. Kenneth Samala.
All right. So, good evening, everyone, and good evening, PSMO. I'm Dr. Kenneth Samala, your moderator for tonight. So, welcome to tonight's virtual event with AstraZeneca in partnership with PSMO entitled Breast Cancer Symposium Redefining Management of Hormone Receptor Positive Metastatic Breast Cancer Patients. So, hope you're all doing well and safe. We have an exciting topic for tonight. And before we formally start, I'd like to share to you the following house rules. Kindly ensure your microphone is muted while the lectures are ongoing. Raise your hand or click on the menu should you have any questions and wait for the moderator to acknowledge you. You may also input your questions in the Q&A button found below your screen. Questions will be entertained at the end of the panel discussion. And this webinar, again, is being recorded. Okay, so let me introduce our tonight's speaker. We are fortunate tonight to have with us an esteemed and well respected speaker. She's no stranger to us as she is a fellow of both the Philippine Society of Medical Oncology and the Philippine College of Physicians. She's also the past president of the Philippine Breast Cancer Society, and she's currently affiliated with St. Luke's Medical Center Global City and Veterans Memorial Medical Center. Ladies and gentlemen, it is my honor to present to you Dr. Cristina Galvez.
Hi, and thank you, Ken, for that wonderful introduction. Pag tumatanda ka palang miiksi na yung nakalagay sa ano mo. So can you see my slides? They can be seen,
Yes,
Ken? Okay, sige. So good evening, everyone. So I know all of you are so tired. You came from your clinics or from work or from errands, and it's 7 p.m. You want to have dinner. So don't worry, I'm going to make this really very lively and just as if we're just having a conversation. Yun nga lang, our conversation is on HR positive breast cancers, right? So, but for tonight, we're also going to focus on other AstraZeneca breast cancer portfolio. Okay. So these are my disclosures. And the objectives for tonight is just to really review the different endocrine treatment options for both early and metastatic breast cancer, and also to discuss the data on the use of fulvestrant. So the focus is on fulvestrant, guys. Monotherapy and in combination with other treatments for HR positive metastatic breast cancer, and to present new approved indication for fulvestrant in HR positive metastatic breast cancer. That is the combinations of your fulvestrant. So yeah, this looks a little like full, but just a brief recap on the evolution of your treatment regimens for HR positive early breast cancers and advanced breast cancer. You know, it's really strange that the evolution for HR positive started as early as 1890s, wherein they found that when women underwent a oophorectomy, their breast tumors, there was a regression of the breast tumors, but it took more than 50 decades before they were able to identify the estrogen in mid 1950s, and the estrogen receptor was only identified in 1970s. So it was really a slow process, and that is why there was the introduction of your tamoxifen, and then it was followed by your first generation aromatase inhibitors until, good thing, during the 1990s, so nearly 2 decades later, there was the emergence of your third generation aromatase inhibitors, and it did improve survival efficacy endpoints for HR positive breast cancer patients. And then, of course, during the mid 90s, 1990s to 2000, there was the emergence of personalized treatments. So there were targeted treatments. It's a good thing that from the mTOR inhibitors in early 2000, now in the new decade of personalized medicine, we are seeing an emergence of newer targeted treatments, specifically your CDK4/6 inhibitors. And we all know how much the introduction of your CDK4/6 inhibitors has changed the treatment landscape for HR positive, HER2 negative breast cancer. So just a brief recap on the treatment according to the NCCN guidelines for HR positive, HER2 negative early breast cancer. So here we can see that it's not any different from your premenopausal to your postmenopausal women. So the only difference is that for premenopausal, there is the addition of your ovarian suppression or your goserelin. So depending on your patient and tumor characteristics, you can give for example, your tamoxifen for 5 to 10 years. You can do upfront AI. You can do a switch or sequence therapy, or you can also give extended adjuvant endocrine treatment or AI, depending on the risk assessment of your patient, right? And this is the treatment regimen for your HR positive advanced breast cancer from the NCCN guideline. As you can see, your endocrine treatment remains to be the backbone together with your targeted agents. We will be touching base with this a little bit later. So this is the AstraZeneca breast cancer portfolio. And as you can see, even in the early breast cancer, your ABC portfolio really impacted the treatment of HR positive breast cancer. So from the early breast cancer, sabi nga ng aking isang daddy in veterans, it's from womb to tomb. So from the early breast cancer, from neoadjuvant, adjuvant, we have your tamoxifen or anastrozole, of course, your goserelin, and then to the metastatic or recurrent setting, we see the introduction of your fulvestrant together with your anastrozole, your tamoxifen, and of course your goserelin again. So this is now the more in-depth, detailed algorithm for the treatment of HR positive, HER2 negative advanced breast cancers. So first, you have to answer two questions: is your patient having visceral crisis, or is your patient having endocrine treatment within 1 year, or more than 1 year, right? So for the first question, is your patient having visceral crisis? For this patient, obviously you give them chemotherapy, but you know what? This may change in the future because there are now real world data that's showing that for patients with visceral crisis, for as long as they're not having significant liver derangements and pancytopenia, your CDK4/6 inhibitors together with your endocrine treatment can work for this patient. Okay, so await for the phase 3 trials for this kind of setting. For those without visceral crisis with prior endocrine treatment within 1 year, obviously for premenopausal, just add your goserelin. For your postmenopausal, you have to shift a different endocrine treatment partner. The rule of thumb is you really have to optimize your endocrine treatment, right? So for those patients who had no prior endocrine treatment within 1 year, of course, you can introduce them to different endocrine backbone. Here, if you look at your far right, upper right of the slide, you can see here the first line therapy, the category 1 recommendations for first line treatment of HR positive advanced breast cancer. And as you can see, it's either you give your CDK4/6 inhibitor together with an AI or your fulvestrant, or you can give fulvestrant alone or in combination with an AI. Okay, so all of these are category 1 recommendation, and you can see that for all of this recommendation, you have your fulvestrant. And we have to know the data that backs up this category 1 recommendation. So for your fulvestrant monotherapy, so we all know this trial. This came from the Falcon trial, from the fulvestrant and anastrozole compared in hormonal therapy naive advanced breast cancer. So patients, postmenopausal women with locally advanced or metastatic breast cancer, of course, they should be HER2 positive, endocrine therapy naive, so they could have a measurable, non-measurable, were randomized to receive fulvestrant 500 on day 0, 14, 28, and every 4 weeks thereafter, or were either given also anastrozole 1 milligram per hour with the primary endpoint of PFS and secondary endpoints of overall survival, response rate, and quality of life. So with the primary endpoint of PFS, we saw a 20% advantage or benefit in PFS in favor of your fulvestrant. So obviously you can see here a clinically meaningful PFS. You can see the curves have really separated. So you have a 2.8 months absolute advantage in favor of your fulvestrant. But what is interesting is that for a group of patients who had no visceral metastasis, the PFS advantage doubled to 41%. So you have a PFS of 22.3 months for your fulvestrant versus 13.8 months. And that is an advantage of almost 9 months, right? And of course, we are familiar with the safety and tolerability of our fulvestrant. So of course, our patients are going to experience menopausic symptoms, bone pains. You have to add and you have to be aware and monitor this, that patients with on endocrine treatment, not just on fulvestrant, are prone to have ALT or AST increases. So what are the other indications of giving or applications of giving your fulvestrant in advanced breast cancer setting? This is in combination with other treatment regimens like your AIs from the SWOG 0226 in combination with your anastrozole, right? Or you can also combine them with your CDK4/6 inhibitors. And so we know for a fact that your endocrine treatment remains to be the important treatment for HR positive advanced breast cancer. Unfortunately, in 40 to 50% of this patient, they are going to have some endocrine resistance, right? And the way to go historically was to give this subset of patients who had resistance to your endocrine treatment with chemotherapy. And we all know that our patient does not want chemotherapy, knowing the toxicity profile of giving chemotherapy. So how can we circumvent this issue or address this issue of not giving your chemotherapy? First of all, you have to understand what are the pathways of endocrine resistance and find a way like which endocrine resistance pathway you can target. So there are two common endocrine resistance pathways. The first one is, of course, your PI3K AKT-mTOR pathway in 70% of patients. And the second one is your activated cyclin D CDK4/6. In fact, the hallmark of an HR positive advanced breast cancer is a dysregulated cell cycle regulatory pathway. And so it is very rational to block your cyclin D CDK4/6, knowing that it is the central hub or the convergence zone for all upstream signaling pathway, which includes your receptor tyrosine kinases and your downstream effector pathways, right? And so through CDK4/6 inhibition, we can overcome endocrine resistance, right? By blocking your cell cycle progression and endocrine resistant breast cancer cells. So these are the 3 clinical trials that backs up the combination of your fulvestrant together with your CDK4/6 inhibitors. You have your Mona Lisa, your Paloma, together with your ribociclib, your Paloma trial in combination with your palbociclib, and your Monarch 2 trial in combination with your abemaciclib. All of them is in the postmenopausal, except for Paloma and Monarch, wherein they also included premenopausal women. What is also different among these three clinical trials is that in your Paloma trial, they included patients who had prior chemotherapy. Your Mona Lisa and your Monarch 2 did not include patients who had prior chemotherapy. So more or less, your Paloma 3 trial, the population are those that who are heavily pretreated. So with the primary endpoint of PFS, you can see here that all of the curves have wonderfully separated. We can see that there is a robust progression-free survival advantage in favor of combination of our fulvestrant together with your CDK4/6 inhibitor. You can see here that the hazard ratios would range from 0.4, so from your Paloma 3 trial, or to 0.5 from your Mona Lisa 3 and your Monarch 2 trials. And you can see that there is an absolute advantage of 8 months with your Mona Lisa, 20.8 months versus 12.8 months. With your Paloma trial, there's an absolute advantage of almost, I believe, 6 months from 99.5 months versus, of course, 4.6 months. And for Monarch 2, you have 16.4 months in the combination arm versus 9.3 months, right? So all of these landmark trials with fulvestrant in combination with your CDK4/6 really shows that there is a great PFS advantage, but not only your PFS advantage. With longer follow-up, we were also able to see that this combination also resulted in a significant OS benefit with your Mona Lisa 3 and your Monarch 2. Of course, there's also an OS benefit with your Paloma 3 trial. So I just wanted to highlight, so because the one that is more comparable is your Mona Lisa 3 OS data for the second line use that is comparable with your Paloma 3 trial. So for the second line use, it's 39.7 months versus 33.7 months. And in your Paloma trial, it was 34.9 months versus 28.0 months, right? Now, for patients who were given in the first line, similar or overall data. So what is similar data is between your Mona Lisa 3 and your Monarch 2 trial. So the MOS benefit is 53.7 months versus 41.5 months. That is a 1 year advantage in favor of the combination with ribociclib. And in your Monarch trial, you can see that there is an almost 10 months advantage, 9 to 10 months advantage with the median OS of 46.7 months for your combination versus 37.3 months for the fulvestrant arm alone. So yes, so not only do you get a PFS advantage and OS advantage, there is also a maintenance of quality of life. And furthermore, I did mention earlier that we want to delay the time to chemotherapy. Through this combination with your CDK4/6 inhibitor, we are seeing that there is a long delay in time to chemotherapy, right? If you remember your data. So what are we going to, what is the future? What does the future look like for fulvestrant in combination with other targeted agents? So we have to first identify what are what are the possible selection of patients wherein we can give your fulvestrant. So this is your Parsifal trial. This is a phase 2 trial wherein it really evaluated which is more superior, fulvestrant with palbociclib or your letrozole with your palbociclib. So patients who were in the first line setting, they had no prior AI. In the metastatic breast cancer setting were enrolled. And here we can see with a long follow-up, 32 months, we can see that the median PFS for your letrozole arm was 32.8 months. And for palbociclib, the median PFS was 27.9 months. Also, they also found out that the 3-year overall survival was not any different between your letrozole and your fulvestrant. It was 77.1% for your letrozole arm, and it was 79.4% for your fulvestrant arm. So this trial did not really establish the superiority between any of the two endocrine backbones, right? So, it's so strange because they were banking on the superiority of fulvestrant from the Falcon trial. So why do you think this happened? You have to realize that patients in this trial are AI naive in the MBC setting, right? Okay. So what is a factor that we should consider here? Maybe, ESR1 mutation. So over the past 2-3 years, activating mutation in ESR1 have been characterized as a important mechanism of acquired endocrine resistance. In fact, ESR1 mutations are detected in 15 to 20% of women with metastatic positive ER breast cancer who had received prior AI. Consider this. The prevalence for patients who had prior AI in the MBC setting is 40 to 50%. Yes, but compared to those patients who had no prior AI in the MBC setting, the prevalence is just 4 to 5%. And therefore, if you're going to give your SERD in patients who are not most likely having ESR1 mutations, you will see that there is no difference when you compare them with an AI. So ESR1 mutations cluster in the ligand binding domain of your ER and result in a. So this is why your estrogen receptor remains hypersensitive. There is a constitutive agonist conformation, and this promotes estrogen independent transcriptional activity. What do I mean by this? So usually your estrogen receptor pathway is driven by the binding of your ligand to your receptor, right? But in patients with ESR1 mutations, you don't need your ligand for your estrogen receptor to be activated. It just remains hypersensitive or activated independent of your ligand. So this can be a problem. So this is a form of secondary endocrine resistance because patients do acquire this resistance prior to an AI treatment. So so ESR1 mutations prevalence is higher, as I've said earlier, in the metastatic setting and in post-AI therapy, notably after an AI therapy administered in the metastatic setting. So how can we measure or detect ESR1 mutations? It's either by using your tissue biopsy, or you can do liquid biopsy using the droplet digital PCR or NGS. But among this different type of measuring your ESR1 mutations, the most sensitive is your ddPCR or your droplet digital PCR. Okay, so the detection of your ESR mutations can prove to be prognostic and predictive of poorer outcome on subsequent treatment with an AI. But you have to be careful with this phrase. Usually, we have always thought that having ESR1 mutations is prognostic of poorer outcomes. And why is this? They have observed that when a patient acquires ESR1 mutations, they also occur concurrently with other genetic alterations and mutations, and therefore would globally have poorer outcomes. So this is the PADO-1 trial. So this is a more intelligent trial because it is a phase 3 trial, because now it incorporates your ESR1 mutations and how we can put in the role of your fulvestrant in the treatment as maybe in the first line for HR positive HER2 advanced breast cancer. So in this trial, all the patients are AI naive. So there are for the MBC setting. So all of these patients were enrolled. They have no prior treatment in the first line setting. So what is different from this from your Parsifal trial is that they did measure every 2 months. Yes, they did measure. They did liquid biopsies using the ddPCR every 2 months. And once they detect ESR1 mutations, in the absence of a progressive disease by RECIST 1.1 criteria, they shifted the endocrine backbone from AI to fulvestrant. Okay, so that is the difference. So with a follow-up 12.4 months, they found that ESR1 mutations, they had significantly shorter median PFS compared to the wild type ESR1, as you can see here, 17.5 months, and it was not reaching the wild type. And this is the data similar to what we saw in the Sophia, the effect trial, where 8 patients who were on exemestane had shorter PFS compared to if they were on fulvestrant. And if you remember your Bolero 2 trial, patients on everolimus plus exemestane had shorter PFS also if they were having ESR1 mutations versus the wild type. And interestingly, in this trial, when they switched an AI plus palbo to fulvestrant plus palbo in patients with ESR1 mutations with no detection of PD, so that's the word. Patients should not have a documented PD. Okay, there was a doubling of the median PFS from 5.7 months to 11.9 months. Now, what happened to those patients who just remained on AI plus palbo, and then they were eventually given fulvestrant upon PD? So there was still a benefit in terms of PFS, but it was shorter compared if you shift them early on to fulvestrant prior to detection or confirmation of a PD. They also detected that in some patients with ESR1 mutation up front, when they were given your palbociclib and AI, there was actually a clearance of your ESR1 mutation. This really shows that your CDK4/6 inhibitor, like your palbociclib, still has an activity despite the presence of ESR1 mutations. But for most of these patients, eventually they were able to detect, or there was a re-emergence or a redetection of your ESR1 mutations. And in these patients wherein they were able to detect again your ESR1 mutations, they observed that these were the patients with shorter PFS. So, what are the trial practice implications with your PADA1? So, this is the first trial that demonstrated that resistant associated mutations in estrogen receptor gene can be detected and targeted before tumor progression, right? It's an acquired mutation. So it's not like your peak three. Your peak three is a early driver mutation. Your ESR1 is an acquired mutation. So researchers of your PADA1 was able to use your plasma-based assay, your ddPCR, to identify your ESR1 mutations, and switching from an AI plus palbo to fulvestrant plus palbo upon ESR1 mutation detected led to a doubling in median PFS. Scientifically, this is a very exciting data, but in clinical setting, practical setting, I mean, who does every 2 months ESR1 mutation? To begin with, we still have to identify a laboratory in the Philippines that will do ESR1 mutation using the ddPCR, right? So maybe Astra can do that for us. So, what are the key takeaways from my lecture or discussion for today from the Falcon trial? It showed that your monotherapy with fulvestrant improved PFS by 20%, but in patients with no visceral metastasis, this doubled to 41%. And the use of a combination of your fulvestrant together with your aramadex from your SWOG trial SO226 showed that there is a PFS and OS advantage. So it's also one of those options. And but what we are driving at is that your fulvestrant really works best when in combination with your CDK4/6 inhibitor. It's like you're thinking of dual blockade. That's you're blocking the estrogen receptor. You're working on the estrogen receptor, as well as you're also trying to block the central hub or the convergence point downstream, right? So what happened is that when you combine your fulvestrant with your CDK4/6 inhibitor, of course, we have observed there is a robust PFS and OS advantage, of course, quality of life and time and delay to time to chemotherapy. Now, what do we do about the data regarding combination of fulvestrant from your Parsifal or your PADA trials? Or your Parsifal obviously did not establish superiority of your fulvestrant versus palbo versus your letrozole palbo, because you were having patients who are more likely to be endocrine sensitive. So in the PADA-1 trial, they were able to show that patients who already have an emergence of secondary endocrine resistance, when they're shifted to fulvestrant, you see a doubling of your median PFS. Good, right? So with that, I think that's the end of my discussion. Thank you, and I'm a proponent of. I really believe that when we all work together, not just us med oncologists, together with our pharmaceutical partners and all allied specialists and our other subspecialist partner, we can do more for our cancer patients. So yeah, thank you.
All right. So thank you once again, Dr. Chiki, for always presenting data and information in a very simple and light yet concise and complete manner. It really makes you
I forgot.
understand the topic
I
better.
forgot
Ah, yes,
something.
Doc.
Thank you.
Ah, yeah. Thank you very much, Dr. Chiki. So really appreciate that. And I personally learned a lot and realized that there is really so much that we can still offer our
Yeah.
HR positive metastatic breast cancer patients, especially during the last part. That's very, I think I find it very exciting. When you presented this probably evolving data on
Yeah.
fulvestrant combination. So something to look forward in the future. Okay, so the virtual floor is formally open for your questions.
Hello, I'm
Feel
laughing. Yeah,
yes,
because
Doc.
I saw there was a question from Patdu. Every time I see a question from Patdu or Dr. Lola, I'm kind of like having palpitations. Or if I'm going to get questions from from Mars and Masa, so I'm like, I'll palpitate, I think. Okay. Anyway, go
Okay, okay.
ahead.
So now we have our question. So again, the first question is okay. Which one should I? I think the an actual so okay. So there's an anonymous question in the chat box. I noticed
Mhm,
that
anonymous.
NCCN also states that fulvestrant and NSAI is also considered category 1 as well. So Dr. Chiki mentioned this. So any
Yeah, true.
data on
You
these
know,
combinations?
I do this in my clinical practice. Yeah. So, this data came from the SWOG 0226, which really did show that there was a advantage in terms of PFS as well as OS with the updated analysis of the SO226 trial. But you have to be careful on choosing what are your patients that you would want to combine your fulvestrant and your anastrozole in the first line setting. So in the trial, they found that this worked because most of the patients were either they had no prior chemotherapy in the adjuvant setting. Patients were either de novo disease, or patients were not heavily pretreated with your AI. So maybe they had only tamoxifen in the adjuvant treatment. So these are the patients that would work. However, I had one patient. I was trying to combine. I was actually combining an AI with CDK4/6 inhibitor. It's actually so I gave palbociclib because the patient had cardiac issues. But it turns out, even with palbo, my patient's QTCF was prolonged, and the cardio
Oh,
said,
okay.
"Don't give it." But so my cardio said, "You have to, change your treatment." And I couldn't also give chemotherapy. The patient had cardio induced toxicity from the previous chemotherapy. I was not the one who did the chemotherapy. Okay, I wanted that clear. So I ended up giving this patient or AI and fulvestrant. This patient had metastasis on the mandibular area. So it was like a 6 by 6 mass on the mandibular area, and it was growing when I was just on an AI. And then when I added fulvestrant, so it took maybe on the second month before I saw that there was response. And the patient was very happy because the face of the patient was slightly deformed. But when I
Mm.
saw the patient last time, the face was less deformed, and the patient was now able to open the jaw without any pain. So I think so it's a worthwhile combination for this patient. And yeah, you
Wow.
have to also look into the interval. So this will work for those patients who had recurrent MBC, but the disease-free interval should be like this. They're saying 10 years or more.
Okay. So that's that. We need to take note of that as well. And just curious, Dr. Chiki, what AI did you use for that particular patient?
Actually, I was because it was
If you want to
giving.
share, if it's
So
okay to
I
share.
actually gave the patient letrozole plus palbo.
Okay.
So we ended
All
up just
right.
continuing with the letrozole, and then I gave the fulvestrant. I know it should have been like anastrozole, but I didn't want to change anymore. And I know I did a
Right.
lecture on that. But your non-steroidal AI would just have the same effect anyway.
Right, and I think as pointed out by our participant, the NCCN says it's NSAI. So I think either way,
Yeah.
it would be fine. Yeah, we have another question here, like you mentioned from Dr. Pampatdu. Are there plans to make ESR1 mutation testing affordable
Affordable.
and available soon? If
I
these
don't
were affordable,
I
when
don't even know
and
how
how
much.
often would you start it?
I don't even know how much they are, Pam, and I don't even know like how frequent should we test them, because like in the Padawan trial they were doing it every 2 months. So even if it's
Every
not
two
that
months.
expensive, you're going to do it every 2 months. It's like, oh my goodness, like how much would that be, right? So I think we should find a way. So I think we need another data that will tell us in practical sense how we're going to measure ESR1 mutation. But I know, in line with this, some people would ask like, when they would say maybe you should test for NGS even at the first line setting, right? The problem with like if you do NGS in the first line setting, you might miss your ESR1 mutation because your ESR1 mutation is an acquired mutation. So you
Acquired.
just test for your PIK3CA, your BRCA, prior to your first line, and you can just really test for your ESR1 post progression on your first line with an AI or together with a targeted agent.
Agree. So probably the next direction for the ESR1 mutation studies is determining the optimal time to
Yeah.
determine it and making it, of course, affordable. Hopefully, I don't know if Astra can help us make that testing more affordable. We
Yeah.
have another question here. We have a comment from Dr. Uzon. Bravo, Dr. Chiki with emojis. From Dr. Grace Nilo. There, from Dr. Grace Nilo. How often do you request for ESR mutation among your HR positive patients who have been through one or two lines of endocrine
Right.
therapy
Yeah. Okay.
already?
To be honest with you, there's not even a. I don't know if there is a laboratory that tests ESR1 mutation, but I would test. For example, I have a patient who had progressed on a CDK4/6 and an AI in the first line setting, and you want to test what you should be giving, what you should be giving your patients for their second line, third line. So, you could request for NGS testing. So you have your Guardian, you have your Foundation One, you have what are the other, they are all available, and I think you can use them all as long as they're FDA approved. I think you can use them in your practice so that you can be guided what to give in your sec. I'm a firm believer that you have to really plan out your patient, like you see them from broader perspective. Like you plan out the first line, second line, third line, so that you have to stretch out all your like it's like you have to stretch out all your tools, or like your what do you call it, your guns, your ammunitions, for
Ammunitions, yeah.
cancer. Yeah, your ammunitions for cancer. You have to plan them out and optimize and maximize their use.
Right. Yeah, so that's a practical tip from Dr. Chiki Galvez. No, when you treat our patients, we look at them and treat and look at it a broader perspective. So we have another question from Dr. Ferdinand Dacumos. In light of
Yeah.
the findings of the PADA-1 trial in relation to the importance of ESR1 mutations, how would you now position your fulvestrant for endocrine
Yeah.
naive HR positive
No,
patients?
that's a very good question because I was thinking about it.
Mm,
So it would make it so it's so because of the SR1 mutation, it's gonna tell you that for first line you're bound to use your AI, right? But the problem is how does but you have your Falcon trial. How does it fit? That's a first line setting. Patients there were endocrine sensitive, right? So I think for postmenopausal women, I would still, especially during COVID, surges, I would still, offer them your fulvestrant monotherapy or in combination with an AI for this subset of patients. But for premenopausal women, I would be more inclined to use your AI in combination with targeted agents. For now, the recommendation are your CDK4/6 inhibitors. So I would still base it on the recommendation on the NCCN recommended data, you know, because they're saying still that your ESR1 mutation is still something that needs to be explored in phase 3 trials, because like I said earlier, your ESR1 mutations occur in combination or concurrently with other genetic alterations. So it's hard to say if it's just the ESR1 mutations that you want to identify, or there are other genetic alterations that needs to be identified together with it. So it's still up in the air. It's really very fluid right now.
Okay, so something to look forward to probably in the next few years. Now we'll know. We have a question from Dr. Crisel. How would you approach post
Mm-hmm.
progression from your
If
CDK4/6
you have
and
a first
fulvestrant?
time, yeah. So this is something that I'm having a hard time, because usually if you gave your patient CDK4/6 plus fulvestrant in the first line setting, it's telling you that the patient had early relapse on an AI. But as per guideline, you can still give your. So if your patient is having PIK3 mutations, you can still give your alpelisib in combination with your with an AI, because there is data for it. Or you can give your chemotherapy, or you can give your mTOR inhibitors together with an AI. So maybe your exemestane, but data. So I think this is from your real world data, di ba, Crizel? The real world data shows that after progression from your CDK4/6, you give your everolimus, your chemotherapy. But right now we're also getting data that you can give your abemaciclib with in combination in monotherapy. Actually, they're saying that in patients with ESR1 mutations, regardless of like you give your fulvestrant or AI, it doesn't seem to be resistant to abemaciclib. So it's something that I think there will be a data that will come out exploring, post progression from palbo or ribo, and then you're giving your abemaciclib together with an endocrine treatment, maybe what exemestane. We don't know. But there are a lot ongoing. So you have your oral ESRDs in the future. So I think there's a lot to look out for in the future. So yeah, we're very. But for now, you can choose from anything, from any of the regimens that is there in the real world setting that was presented by Pfizer, according to Frizzell. Astra is because Frizzell was asking. Okay.
Yeah, and it's always like it's this is an opportunity for all of us to like to learn. So I think
Yeah.
that's one thing that I think it's exciting, though, definitely because Abema I think
Like I
is
said,
probably
like I
launching
said,
soon. Yeah,
it takes a community to help cancer patients. So we just have to be, all pharma, all doctors.
I agree. We have one goal, and that is to help
Yes,
our patients live longer. Definitely.
right.
Um,
That's right.
I'm just I'm just checking the chat box if there are any more
How do you
questions.
choose
And now this time we have a question: how do you choose what to combine to CDK, AI
your
or your
fulvestrant?
fulvestrant?
If I have a patient up front who I've detected, so usually, it's not recommended. If you have a HR positive, HER2 negative advanced breast cancer patient, you have to really test for PIK3CA mutation very early because it's an early driver. So if I have a patient with PIK3CA mutation already, then I know I would want to, systematically position my endocrine treatment according to the better partners. So I would give in this case your CDK4/6 with an AI, and then followed by alpelisib with your fulvestrant. Of course, you can but if your patient turns out to be BRCA1/2 positive, then you can still have an option for your PARP inhibitors. But overall, I'm still a proponent of giving your CDK4, sorry, still, because from the Parsifal trial, in the first line setting, I'm still a proponent of giving your CDK4/6 with an AI.
AI.
I think it's more of a practicality because it's an oral thing. It's really just that, and of course, it costs it. You know, just practicality because you still have your Parsifal trial to back you up. But if your patient but for early relapsers, like within, with you're still on your AI and then the patient already progressed, then yeah, you would be thinking of now combining CDK with the fulvestrant, right?
Agree. And this is exactly what you've mentioned a while ago, no? Like looking at the broader perspective and really planning the treatment for your patient. So hopefully, again, no, the other genetic mutation studies will be more affordable in the future that will help us guide in our treatment for our metastatic breast cancer patients. So let me
Yeah.
just check again, once again, if there are any
Well,
questions. There are a lot of questions on ESR mutations, so I think it's a lot of our participants are very
oh my
interested in
god,
this
I
new
opened the
data.
Pandora's box. I told you it's a good. It's like opening Pandora. Oh, you know what? There's a good data. The Pearl study. The Pearl study actually showed that when like, because they realized that they were enrolling patients on that were AI that progressed prior to AI. So these are AI resistant tumors, right?
Wow.
The Pearl
Okay.
trial. So they evaluated first. So the first cohort was comparing capecitabine versus palbociclib plus on AI. And then they realized, oh no, we randomized AI resistant tumors, so we should include fulvestrant. So they added a second cohort, right? And so this time they included your fulvestrant. And one of the subset analysis showed that patients with ESR1 mutations, when they were treated with fulvestrant, they had the same PFS versus the wild type as long as they were on fulvestrant plus palbo. But patients who were on AI plus palbo who were ESR1 mutation positive, and so those with ESR1 mutations, they had a shorter PFS compared to those who were ESR1 wild type. So there is really a role. There's something about ESR1 mutations.
Yes,
So yeah.
R1. So kind of similar to what the PADA-1 trial presented, that they have
Mm-hmm.
shorter median PFS um,
Yeah.
if they do have the mutation. So very, very interesting times. I think data, of course, will definitely evolve in the next few years. So
Yeah. But it's just
very
strange
exciting.
though, right? Yeah, but it's strange though. In the Paloma 3 trial, it shows um, that patients who have mutations with ESR1 mutations, they had shorter PFS, even if, when you
If you,
compare it to
yeah,
overall, even if they were given CDK4/6, compared to those patients with or ESR1 wild type. So yeah,
Yeah.
so it's really
It's still, like you said, up in the air. There's still probably something um, happening there. Also from Dr. Uzon, bravo, Dr. Chiki, with emojis.
Dr. Uson, I want a real hug when we see face to face, all right?
Okay. So
Okay,
thank you. I'm checking the Q&A. I think that's the last question. So thank you very much,
thank you.
Dr. Chiki Galvez, for always giving us a very informative, concise, very and presented it in a very light and simple manner. So it's very easy to understand and really enjoyed. Like you said, no, we're just think of it that we're just chatting, but our topic is HR
We're all
positive
tired. We're
management.
all tired people, We should, change the way we do our discussions.
Right, right. So that's it. So thank you very much again to all our participants and to everyone who gave their questions as well. And hope you enjoyed our tonight's RTD. So I'll now bring you over to AstraZeneca.
Thank you so much to our speaker, Dr. Cristina Galvez,
That's it. So
and to our
thank you very
moderator,
much.
Dr. Ken Samala, for that insightful and engaging discussion.
You
To
enjoyed
help us improve our
our
scientific events,
So I'll now
may
bring you
we
over
kindly
to
request to please
AstraZeneca.
answer the post event survey by scanning the QR code posted in the screen or clicking the link in the chat box. And to formally close the program, may we now call on Dr. Chris Kalin, Medical Advisor for Oncology.
Good evening, doctors. On behalf of the organizing team of AstraZeneca Philippines, we warmly thank you for your time and presence this evening. We hope it has been beneficial for you and your HR positive breast cancer patients. AstraZeneca is committed to co creating educational meetings with experts to provide meaningful use of your time amidst the multitude of webinars and virtual meetings you, our dear medical oncologists, are invited to. Thank you to PSMO for allowing us to have this educational meeting. Of course, our sincere thank you to Dr. Cristina Galvez, according to Dr. Uson. Bravo for that lively and very informative lecture. And thank you, Dr. Kenneth Samala, for helping us with the module and the moderation of this symposium. It is also my pleasure to announce that olaparib, a novel PARP inhibitor, has been approved by the Philippine FDA for treatment of 7 indications across 4 tumor types, namely metastatic breast cancer, advanced ovarian cancer, metastatic pancreatic cancer, and metastatic castration resistant prostate cancer. Should you need more information on the specifics of these approved indications and testing requirements, as well as AZ Care's testing, please contact an AstraZeneca representative. With this, you are all cordially invited to the launch of olaparib happening on April 6th at 6:30 in the evening. Please save the date. Thank you again and have a restful evening.